This is Lacey Songer. I'm a registered nurse and an FNP student in the master's program here at ASU. I'm going to be doing a poster presentation on peripheral arterial disease screening. Peripheral arterial disease, or PAD, is often asymptomatic and therefore it is an underdiagnosed disease. According to the CDC, approximately 8.5 million people in the U.S. have PAD. 12 to 20% of those individuals are older than the age of 60. It is expected by the year 2040, atherosclerosis will have a huge financial impact on medicine. Therefore, prevention, early detection, and treatment are crucial. There is an increased risk of death, cardiovascular disease, functional limitation, as well as limb loss associated with PAD. After coronary artery disease and stroke, PAD is the third leading cause of atherosclerotic cardiovascular morbidity. The American College of Cardiology and the American Heart Association have recommendations for PAD screening. They recommend to screen with ankle brachial index, ABIs, in patients at increased risk. This includes adults greater than or equal to the age of 65, adults greater than or equal to 50 years of age with a history of smoking or diabetes, and adults of any age with exertional leg symptoms or non-healing wounds. The objective of this study is to compare the percentage of patients 65 years of age or older that have been screened for PAD in a rural Arkansas clinic to the national average of primary care providers who use ABIs in their practice. This picture shows on the left a normal artery with no plaque buildup with good blood flow. On the right is an artery with plaque buildup, which causes a narrowing of that artery, which results in decreased blood flow to the peripheral extremities. This is a descriptive study, and it was conducted at a rural Arkansas clinic through a retrospective chart review of 50 electronic medical records. Inclusion criteria included males or females 65 years of age or older, and the exclusion criteria was males or females less than 65 years of age. The population included males and females greater than 65 years of age. Smoking status was an additional consideration, as well as coronary artery disease diagnosis. The study found that the rural clinic in Arkansas had a 0% screening rate for PAD using ABIs compared to the national average of 30%. This is just a graph chart that shows the percentages of the Arkansas rural clinic compared to the national average. This study found that the rural clinic in Arkansas was significantly lower than the national average of 30% of providers in family practice that use ABIs to screen for PAD. However, the guidelines continue to be inconsistent with screening recommendations for PAD. While the ACC and the AHA have their guidelines, the U.S. Preventive Task Force has guidelines that are still indeterminate concerning PAD. With PAD expected to continue to increase and the risk associated with PAD, which include coronary artery disease, stroke, and potential limb loss, the results of this study prove that PAD needs continued research, including the possibility of other screening methods that family care providers would be more apt to use in their practice. Acknowledgements: Dr. Christopher Jordan was my mentoring faculty, and references are as follows. Thank you.